I am pleased to present motivational interviewing during patient care to support positive oral self-care behaviors. During this lecture, I will define motivational interviewing, describe the meaning of the spirit of MI, identify motivational interviewing principles, guiding strategies, and discuss the motivational interviewing process. I will also describe brief motivational interviewing, which is applicable in a dental setting. Our first focus is oral diseases and individual behavior. Our lifestyle choices, behaviors, habits, and what we consume affect our oral health and our general health. Having good oral health impacts an individual's life, speech, social development, and reflects general health and well-being. A positive change can improve an individual's oral and general health. Oral diseases such as decay, periodontal disease, and oral or pharyngeal cancers can be prevented or reduced, yet these are still prevalent among the patients we treat. We also have evidence that poor lifestyle behaviors increase the risk of these oral diseases among other chronic conditions. This complex relationship between individual behavior and lifestyle contributes to oral and systemic diseases. However, evidence indicates a positive behavior change can reduce chronic diseases. As oral healthcare providers, we deliver information and educate patients as part of our daily clinical practice. However, have you ever wondered why patients do not apply our advice to reduce their plaque score or their bleeding sites, risk of caries or periodontal disease? Well, let me provide a bit of information to explain why. The most common patient education method used in dentistry is tell, show, do, which is, as a provider, I tell the patient their problem. I show them how to fix their problem, and now the patient will do exactly as I said, change the behavior. It's like magic. Well, that's not the reality for the majority of decision-making individuals. This method does not work that way. Advice-giving methods such as tell, show, do not promote positive, lifelong behavior change. It actually can impair a patient to change a behavior. Evidence-based behavior science research confirms this strategy does not motivate and that patient-centered counseling is an effective method to support a positive behavior change to reduce chronic diseases. Before I define motivational interviewing, which is a patient-centered counseling approach, I need to provide some information on behavior change models. I will focus on the health belief model and the trance theoretical model. The health belief model suggests that individuals are more likely to take preventive action if they believe the threat of the health risk is serious. The centralized core of the health belief model is the individual's perception about them being susceptible to a disease, benefits of the prevention or the treatment of that disease, their perceived barriers of the behavior change, intervention, or treatment of the disease, and their self-efficacy, which means their confidence in his or her ability to successfully perform a behavior to prevent or cure a disease. The cue to action that may result in a specific behavior is that stimulus that is needed to trigger the decision-making process to accept a recommended health action. These cues can be internal symptoms such as a toothache, swollen gums, or the inability to chew food. These cues can also be external, such as advice from others, seeing a family member with the same disease, or an article posted on social media. Understanding the health belief model and identifying your patient's perceptions regarding the impact a disease has on their oral and general health can provide insightful information when applying motivational interviewing during patient care. The second model is a trans-theoretical model, also known as the stages of change. This model focuses on the decision-making process of the individual. This model assumes that individuals do not change behaviors quickly or decisively, and behavior change is a process. This model indicates individuals move through 6 stages of change. During the pre-contemplation stage, an individual is not thinking of change, nor do they believe their behavior has an impact on their health. The contemplation stage is when the individual has some awareness their behavior has consequences on their health. During this stage, an individual has ambivalence for change, meaning they are weighing the pros and cons of a specific behavior change. The determination stage is when the individual has made a commitment to make a positive behavior change. The action stage is when the individual believes they have the ability to change their behavior and are actively taking steps to change that behavior that impacts their health. The relapse stage, it is inevitable and part of the process. In many cases, individuals are resistant to change, or they do not see results fast enough, and they resort back to prior behaviors. A lifelong behavior change takes time and work. Ideally, an individual will not relapse and move into the next phase of maintenance. In the maintenance phase, an individual is able to resist temptation of the prior behaviors that had a negative impact on their health and well-being. They are also able to be mindful of the work and steps they made to get this far. Keeping the stages of change in mind while applying motivational interviewing during patient care to support a positive behavior change is beneficial to know which strategies are most effective to support a patient with ambivalence of change in the contemplation stage, to evoke their own motivation and support them as they move through the stages of change. Motivational interviewing is an evidence-based, patient-centered, collaborative counseling approach where the provider and the patient build a partnership that focuses on strengthening the patient's motivation for a positive behavior change. A role of the provider's partnership is supporting the patient to overcome their ambivalence and initiate change conversations. Patients are more likely to be persuaded by what they hear themselves say compared to what they're told to do. As I proceed, I will also refer to motivational interviewing as MI. MI is an adaptable in a variety of health practices and has been successful since the 1980s in addiction therapy, weight loss management for type 2 diabetes, and smoking cessation, to name a few. MI is adaptable for oral health care and should be used instead of tell, show, do to support behavior change. When practicing motivational interviewing during patient care, it encompasses a philosophy known as the spirit of MI. This can be described when a provider and a patient have developed a collaborative partnership. The provider will have an attitude of acceptance for the patient. This does not mean that you have to agree with your patient's choices, but you cannot judge your patient for their choices. Compassion is the ability to actively promote the patient's well-being and give priority to their needs. This means making the conversation about them and avoid I statements, such as, I think you should brush your teeth more. Evocation is drawing out the patient's own thoughts or ideas rather than the provider imposing goals or expectations set by the provider. So again, you want to avoid I statements and ask open questions to find out what the patient wants to achieve. When these 4 components are demonstrated by the provider, it builds rapport and trust for the patient-provider relationship and will enhance patient autonomy. Applying MI during patient-provider conversations encompasses principles, guiding strategies, and rules that make up an MI process. The application of MI by a provider requires training, coaching, and feedback to be effective. The goal of this presentation is to provide some strategies to incorporate this communication approach into your clinical care. There are 4 main principles of MI, which allows a patient to maintain their autonomy during the behavior change process. Empathy focuses on the provider's ability to show interest in understanding the patient's perceptions. This is not pity, but rather understanding the patient's feelings towards a behavior. Developing discrepancy focuses on distinguishing between the patient's values and behaviors that are inconsistent with their behavior change goal. For example, a patient may state they do not want to lose any more teeth to periodontal disease, but the patient's also not consistent with their home care. This is an example of the patient's behavior not aligning with their goal. Rolling with resistance may also be referred to as avoiding conflict, which is a key MI principle. When a provider identifies patient resistance to discuss a negative behavior and the provider responds with support instead of advice giving or chastising the patient for their behavior, it may minimize the patient's ambivalence and offer valuable insight to the patient's internal challenges. Self-efficacy, which is giving encouragement and praise to build confidence in the patient's ability to change a behavior. Keeping the MI principles from the previous slide in mind to support patient autonomy, there are guiding strategies that are helpful. Moving forward, you will notice motivational interviewing has many acronyms. The first acronym we will discuss is OARS. OARS represent open questions, affirmations, reflections, and summaries. Open-ended questions are those that cannot be answered with a yes or no statement from the patient. Posing a question that provides an opportunity to craft a response will allow the provider to understand the patient's perceptions. Affirmations are achieved by giving encouragement and acknowledgement to the patient's strengths. Reflections allow a provider to display an understanding of the patient's perceptions, ambivalence, and efforts. It also helps the patient hear their own statements of thoughts and feelings in a different format. The purpose of summaries is to close the MI session. You don't want to get stuck on the hamster wheel where you're repeating open questions, you're affirming and reflecting, and you're not getting anywhere, you're not concluding the MI session. So the purpose of summary is just to close the MI session, and it also allows the provider to understand the patient's perceptions and connects the information provided by the patient. It also lets the patient know that you were listening to their challenges or their concerns. To be effective utilizing OARS, you must be able to demonstrate reflective listening, also known as empathetic listening. Reflective listening is being fully present with the patient, refraining from talking about oneself or giving advice, and using reflective statements that assure the patient you are listening and understanding their feelings, thoughts, and needs. This video clip is from the 2015 Disney Pixar movie Inside Out. In the clip, Bing Bong loses something that is very important to him. Joy approaches Bing Bong and tries to distract him from his feelings and tries to push him to move on to the train station. Sadness, on the other hand, provides reflective statements to let him know she is listening and understands his feelings. This approach of empathetic listening and reflective statements encourages Bing Bong to feel better, and he makes the decision to move on to the train station without receiving advice or being told what to do. During the video, please pay attention to Joy's approach with Bing Bong compared to Sadness's approach.
No, you can't take my rocket to the nuts. Riley and I are going to the moon. really can't be done with me.
Hey, it's gonna be okay. We can fix this. We just need to get back to headquarters. Which way to the train station?
I had a whole trip planned for us.
Hey, who's ticklish, huh? Here comes the tickle monster. Hey, Bing Bong, look at this. Oh, here's a fun game. You point to the train station and we all go there. Won't that be fun? Come on, let's go to the train station.
I'm sorry they took your rocket. They took something that you loved. It's gone. Forever.
Sadness. Don't make him feel worse.
Sorry.
It's all I had left of Riley.
I bet you and Riley had great adventures.
Oh, they were wonderful. Once we flew back in time. We had breakfast twice that day.
Sadness.
It sounds amazing. I bet Riley liked it.
Oh, she did. We were best friends.
Yeah, it's sad.
I'm okay now. Come on. The train station is this way.
All right, so I'm glad we got that audio worked out because the next video is even better. So when applying the MI guiding strategies of OARS, and you are empathetic listening, reflective listening, you want to pay attention for change talk, or you want to evoke change talk conversation. When listening to your patient and trying to understand their ambivalence for change or their readiness to change, the acronym DARN can be used. Desire statements are when the patient states, I want, I should, I wish. Ability statements are I could, I can, I might. Reason statements from the patient may need some evoking from the provider. For example, a patient may say, I would have less bleeding if I flossed more. The provider could pose an open question such as, how would flossing fit into your home care routine? This will allow the patient to think about a specific behavior or action, such as flossing, and how that could be a part of their daily routine, and perhaps come up with their own plan. Need statements are a bit easier for a provider. If you hear a patient say, I need, I must, reply with the affirmation to build their confidence in his or her ability to be effective. Another acronym for change talk is CAT. These are statements that indicates a patient is ready for change. If you hear these type of statements, I'm going to, I'm ready, this allows the provider to go back and use OARS and ask an open question such as, how will you make this change? What will you do next? This will allow the patient to share their plan with you. Now with MI, there's always rules that need to be followed to align with the spirit of MI and MI principles. The first rule, and maybe one of the most important rules, is resist the writing reflex. This means we do not fix or change the patient's behavior, impacting their health and well-being. If you try to fix your patient or offer advice without permission, it can actually impair them from making their own decision to change a behavior. The next rule is understand. As a provider, you want to demonstrate you understand the patient's motives, their perceptions for change, and their challenges for change. When a provider has a better understanding of what motivates the patient, they are more likely to provide acceptance for the patient's challenges. Listening with empathy is the next rule. This really aligns with the spirit of MI to demonstrate compassion for your patient. And it's always a good reminder that empathy is not pity. We are not going to pity our patients. The last is empower. The goal of MI is to support patient autonomy and build their own self-efficacy for change. Thank goodness we got the sound to work, because this by far is probably one of my favorite videos. For many providers, The patient's behaviors that negatively impact their oral health are obvious to us. It is oftentimes very difficult as a healthcare provider not to state the obvious to our patient. It's very easy to slip back into old communication approaches and provide advice and tell the patient what they should do. In this video, it's a woman and a man having a discussion. The woman's problem is obvious, and the man tries to tell her what the problem is. The more he tells her what the problem is, the more frustrated she becomes.
It's just, there's all this pressure, you know? And sometimes it feels like it's right up on me, and I can just feel it, like literally feel it in my head, and it's relentless. And I don't know if it's going to stop. I mean, that's the thing that scares me the most, is that I don't know if it's ever going to stop.
Yeah. Well, you do have a nail in your head.
It is not about the nail.
Are you sure? Because, I mean, I'll bet if we got that out of there...
Stop trying to fix it.
No, I'm not trying to fix it. I'm just pointing out that maybe the nail is causing...
You always do this. You always try to fix things when what I really need is for you to just listen.
See, I don't think that is what you need. I think what you need is to get the nail
See, you're
out.
not even listening now.
Okay, fine. I will listen. Fine.
It's just, sometimes it's like there's this achy, I don't know what it is. And I'm not sleeping very well at all. And all my sweaters are snagged. I mean, all of them.
Yeah, that sounds really hard.
It is. Thank you. Ow!
Oh, come on. Ow. If you would just...
Don't!
Try to see things my way.
One of my favorite videos. He did get one reflection, and he did say that sounds really hard. So he did get one reflection in. The MI process comes full circle when trust and rapport between the patient and provider is established. Engaging is more than being friendly. It is the development of a relationship and a rapport that involves trust and understanding. This will take more than one dental visit. This takes many dental visits over a period of time. The process of focusing will assist in defining the direction to achieve a health behavior change goal. Applying the MI guiding strategies of OARS, listening for change talk, and following MI rules will help the provider support the patient's focus of their own goals. Evoking is eliciting the patient's internal motivation for change. Evocation is the heart of MI and enhances patient confidence to support autonomy of their ideas, feelings, and beliefs towards a behavior change. Planning occurs only when the patient has reached their potential level of readiness to change a behavior. This requires a commitment and an action plan that may need to be revisited multiple times as the behavior change evolves. Please be very mindful that this MI process is very, very unlikely to happen at one dental visit. This takes time, this takes work. This is not a one-time 5-minute intervention and we are planning to change a behavior with a patient. Because motivational interviewing is so time-consuming, the application of brief motivational interviewing, which is a derivative of MI, is intended for healthcare providers that have limited time, such as dental hygienists, dentists, dental assistants, that have only 10 or 15 minutes to have these type of discussions with their patients. Its focus is the collaborative spirit of MI, allowing the patient to think about the benefits and the challenges of change. The overarching goals of brief motivational interviewing is to assess the patient's motives, raise their own awareness, and support behavior change. When applying brief motivational interviewing, the Elicit provide Elicit technique is an effective way to find out what the patient already knows. fill in the gaps or correct any misconceptions the patients may have, and explore how this will fit into the patient's life. This is a time-saving strategy that both validates patients' knowledge and allows time to address barriers. The first step is to elicit by posing an open question, such as, what do you know about diabetes and gum disease? What do you know about vaping and gum disease? What do you know about bleeding around implants? What do you know about diet and tooth decay? By posing an open question, the provider will be able to determine the patient's level of knowledge and understanding of a specific condition or a disease. Additionally, the provider will be able to acknowledge and affirm their awareness. The next step is to provide information, but please note, you must ask permission before you share information. This can be very simple, such as, may I share some information about diabetes? May I share some information about bleeding around implants? A very simple permission statement. This is essentially maintaining the spirit of MI and allowing the patient to maintain autonomy. The goal of Elicit, Provide, Elicit is to provide objective, factual information that is non-judgmental. So again, you want to avoid I statements. And you want to be careful with you statements with Elicit, Provide, Elicit. If you begin with I think or you should, then you are not aligning the spirit of MI. Instead, you could begin with statements such as research suggests, studies have shown, others have benefited from, we now know in dentistry. Those are ways that you can remove the I and the you and state objective, non-judgmental opening statements to provide information. After you provide that information, you want to find out what that means to the patient. How do they interpret that information? The next step is to elicit again. So this time you're actually eliciting their perceptions of the information you provided. To do this, you're posing another open question. What does this mean to you? How can we work together? Where does this leave you? What do you think about the information that was provided? The patient's response will help you gauge their knowledge, perception, and readiness to change. It is okay if the patient's not ready to change. Remember, it's not our job to fix the patient. Our goal is to evoke their own motivation for change. The EPE is a great way to incorporate brief motivational interviewing during conversations while applying OARS, listening for change talk, and following MI rules. I will end with 2 more video clips. The first clip is a provider not using motivational interviewing. The provider gives advice to the patient and also has statements that are judgmental to the patient's choices. So again, this video is not motivational interviewing.
Hi, Emily. How are you?
I'm doing right. How are you?
I'm good. Wow. What's changed? What do we have here?
Oh, I got my lip pierced.
Emily, why? Why did you get your lip pierced?
Well, I don't know. Wanted to change and
You're
seemed kind of cool.
Gorgeous. Your teeth are lovely. You do not need a piercing.
Well, I mean, nobody needs a piercing. I wanted one.
Do you know what those oral piercings can do to your teeth?
Well, I mean, it's my lip that's pierced, not my teeth.
Well, yes, except that you know what's going to happen. See how, do you feel how when you're moving your lips, smile for me? Okay, so do you see how when your muscles are moving, that piercing is rubbing against your gums as well as your teeth? So we can see some recession that's going to start to happen.
Yeah.
Possibly affecting the tooth itself, chipping the tooth, etc. So it's something that we definitely don't like to see.
I mean, it's been okay so far. It hasn't caused me any problems.
Well, it's only been a month.
Yeah.
I think or early days yet, and it might not be a bad idea to reconsider the piercing.
Well, I mean, I just put it in. I'm not going to take it right out. it's like you said, I've only had it in for a month. I mean,
Emily, I've been seeing you for so long, and you know that I really I think you have lovely teeth, and I've watched you, just mature, etc. And I'd hate to see you wreck your teeth for something like this. I really would.
well, I mean, if it starts to cause a problem, then maybe we can talk about it. But at this point, I mean,
all right, okay,
Yeah.
okay,
Yeah.
okay. We'll continue with the exam, but you know where I stand on this, okay?
All right.
Yeah.
So again, that video was not utilizing motivational interviewing OARS, the guiding strategies, following any MI rules. Now this video definitely aligns better with the spirit of MI. I really want you to pay attention to the provider's open questions and her reflective statements. Please be mindful of the body language the provider has, and Emily, the patient, be mindful of her body language as well. There is one thing I do want to point out with this video. The provider does a really good job of provide elicit. However, the provider does not ask permission before sharing information. Now, one could argue that how fluid the conversation is and how Emily's body language is, you could say that permission was implied, but to actually do EPE, you should be asking for permission.
Hi, Emily. It's been a while.
Yeah, it's been a while.
This is something new.
Yeah.
You got your lip pierced. How long ago did you get that done?
About a month. Yeah.
What made you decide to get a lip piercing?
I don't know. I just felt like something different. I was getting bored.
Yeah.
And I don't know. It's kind of nice to stand out a bit, I guess. Yeah.
Yeah,
change.
it looks nice.
Thanks.
I guess, as your dentist, I have a couple of concerns about lip piercings, oral piercings. I wonder, what have you heard about how having an oral piercing can affect your teeth or your gums?
I actually don't really. I mean, I'm sure that it might push on my gums or teeth, but I don't know how much it will impact that much. I've pretty good teeth. I don't know.
You do. You have beautiful teeth, as I always tell you every time you come in.
Yeah.
I mean, I have had some patients with oral piercings, and they can erode some of the gum just right there at the front. So that's one thing. And the other is I do see a fair amount of chipped teeth just from contact with it. I wonder, what are your thoughts about that?
Well, I definitely don't want to mess with my teeth. I know I kind of already have low gums to begin with, like you've been telling me for a while, and I have to floss.
Yes, flossing.
Which I'm not doing. But yeah, I guess I don't really want to wreck my teeth because, I didn't really notice any of the chipping.
There's nothing yet. Yeah, there's certainly there's no problems, and you, as you said, only have had it for a short time. What would make you decide this is something that's not right for me?
I don't know. I guess if I started to see that it was actually causing a problem, then I might. But for now, I just got it, and I think it looks pretty cool.
Like I said, it does. Yeah, it looks nice. So you want to monitor it and really watch the effects? Okay.
Yeah, I guess if I really start to see a problem, this might not last forever, but my teeth, I'm hoping, will kind of stick out.
Emily, you said it so well.
Yeah.
The piercing might not last forever, but your teeth really are, hopefully forever. So, okay, well, thanks for talking about it with me. And also, before I do the exam, I'm always on your case about flossing, so maybe we can take a couple.
So at the end, the provider did a really nice job of summarizing Emily's overall conversation. So thank you for your time. If anyone's interested, here are the resources. If you're interested in learning more about motivational interviewing or brief motivational interviewing, there are courses available for training if you are interested. And thank you very much for your time, and we will open up for questions. So it looks like there's 2 questions. Basically, common sense, careful thinking, specific action. Yes, one could say that it is common sense not to be judgmental or to put your own views onto the patient, but not every provider practices that way. Next question, as a provider, who uses MI? How do you assist colleagues in the office that are stuck in traditional lectures? Oh, great question. I would say that dental hygienists would use MI the most because we have the most time to really have discussions and provide patient education. So MI is very applicable for dental hygienists. How you help someone in the office that constantly lectures, I think one of the ways that you could maybe do that is suggest an MI training session for an office and have everyone go through an MI training session and hope that it helps the person that is always lecturing the patients. Because evidence says that lecturing or advice giving is not supportive of lifelong positive health behavior change. Great question. What do you think about TED Talks and motivational interviewing? Oh yeah, I think the TED Talks, I mean, anything TED Talk is generally really good. So anytime you can take any motivational interviewing CEs, training, read on it. MI really takes a long time to be good at that skill. I have been practicing MI for 7 years. I've been researching it for 7 years. I still take training courses. I still participate in training courses where I can audio tape conversation and have an MI expert listen to those conversations and score me so I can get feedback on how to improve. This is not a skill that is just learned overnight. Any tips for interactions with kids? Yes, actually interesting. They're doing quite a bit of MI research with kids, and I'm glad this question is brought up because I don't want to discredit tell, show, do. Tell, show, do is still an evidence-based approach for children, for individuals with cognitive impairments. Tell, show, do is great for post-op instructions, just like teach back is best for post-op instructions. But with kids, something that I know others have done in dental practices, if time allows, putting a tray out of all the different toothbrushes, interdental aids, different aids they can pick from, and asking the child to choose what's most interesting to them, disclose their teeth first, have the child try different aids of brushing or flossing and looking in the mirror and having the child figure out what dental aid removes more of that disclosing solution. So if you have an extra 5 minutes and you can set that up in advance, if you have a pediatric patient in, let them pick whatever aids they want and demo their home care, and then they can pick and choose on what works best for them and what got the purple off their teeth. So yes, another great question. All right, is anyone at the School of Dentistry doing research on MI? If so, what are the research questions? Oh, good question. Yes, I am running a blinded clinical trial right now. Yvette Reibel is my blinded examiner. Dr. Blue and Lisa Amon are my MI raters. The study is closed for enrollment. There are 60 subjects enrolled in this study, and we are comparing brief motivational interviewing to traditional tell, show, do. And our outcome measures are plaque score, bleeding on probing, and GI. So that's currently the only MI study going on at the School of Dentistry. We were looking to wrap up the study in June, but with COVID-19, we're on a bit of a pause right now. But we are hoping to get back into the clinic and wrap it up. And we're shooting for publication dates next year. All right. How do you try to encourage patients to do periodontal scaling without trying to make the patient feel lectured? Okay, that's a touchy area because a lot of other factors may play. It may be their health literacy. It may be their access to care. It may be finances. Many patients may not be per se open to scaling and root planing for some of those reasons. So again, just trying to be supportive and providing information if they are receptive to information on how it can benefit their long-term periodontal health and their overall health. But again, MI shouldn't be used to push people into treatment. MI is useful for behavior change. So it's not used as a tool to make people consent or agree to treatment. So that can be kind of a touchy area, but again, just supporting and trying to provide knowledge so they can make an informed decision and have autonomy over their treatment, whether or not they want that treatment or not. All right, are there other models for MI? Do you mean, I guess with that question, I need a little bit more clarification, other models for MI. There's different behavior change models, the two I discussed, the health belief model and stages of change that align with behavior change process that can be applicable when applying MI, but there's not another patient-centered counseling approach. I hope I answered that question correctly. If a patient's uncooperative, what should we do? Roll with resistance. If you remember the rules, you want to resist the writing reflex, so you want to resist giving advice, and then you want to make sure you roll with resistance. If a patient is resistant to have a conversation about a negative health behavior, or the patient is displaying some sort of being uncomfortable, you want to just try to end and diffuse the situation. The second part of the question, oh, it's going so fast. There was another part of the question about kids. I'm sorry, the screen went so fast and now that question went away. Can you recommend any strategies for clinic where patients aren't compelled for a single provider, but see someone different at each visit? The only thing that you could do if they're not seeing the same provider and they're seeing many different people is perhaps get the office on board, get some office CEs where there are strategies in place where the whole office is MI trained. And it actually has to be embraced by the whole office if someone's going to be seeing multiple providers. So the best advice I can give you is maybe trying to be the leader in your office and getting some CE courses where everyone can join in on those CE courses and get everyone to buy in to this patient-centered counseling approach. Because if you have one person not buying in, then it's going to change how it's delivered as that patient goes from provider to provider. All right, any advice on incorporating MI into the time that you are also presenting treatment, finding the treatment plan with the dentist? Yeah, actually, a way to incorporate MI if you're presenting treatment plans, just like I teach treatment planning at University of Minnesota, and I'm from the Detroit, Michigan area, so we have the Cadillac treatment plan, we have the Malibu, and then we have the used car. So again, presenting multiple treatment plans that can all benefit the patient as long as you're explaining the benefits and the risks, and then just allowing the patient to use autonomy, that shared decision-making process, and letting the patient choose which treatment plan is best for them. And that can be done collaboratively with the dentist in the room, the hygienist, and the patient. The hygienist can be the facilitator, telling the dentist, these are the findings today, these are the different treatment options that were recommended, and you guys can talk about it as a group. Do you know any CE trainings and offices can purchase using a team meeting? For MI training, if you go to the MINT, M-I-N-T, that is the Motivational Interviewing Training website. You can find MI trainers. You can perhaps even get a trainer to come to your office and train the office, but that is probably the best resource to find MI training courses. All right. So when we're doing a perio exam, should we ask permission to explain the findings and advise disease? Ask what they think. Great question. And ask if you would want some treatment plan options. So there's a fine line. We do have a legal ethical obligation to inform our patient of our assessment findings and our dental hygiene diagnosis and make them informed if there is disease, if there's active decay, if there's a lesion that we're concerned about that may need a biopsy. So in those cases, MI, you can follow the spirit of MI and make sure that you're being non-judgmental and you're giving factual, objective information, but we still have that ethical, legal obligation to inform our patients. So with the perio exam, we should be explaining what's going on, what our findings are, but when it comes down to their home care habits, if their periodontal health could be improved with electric toothbrushing or flossing or antimicrobial rinse or something they can do at home, a behavior they're not doing, that's when we want to roll out MI. And we want to find out what are they doing to take care of their gums? What's your home care look like? Find out what they are interested in incorporating in their home care. But we still have that legal, ethical obligation to inform patients when we find disease. So hopefully I clarified that. All right. Do you have advice for providers to spend more time with patients? Oh, I love having more time for patients. I feel like I could have MI conversations for hours. If you have more time for patients, and that really allows you to build that trust and that relationship and ask open questions and find out what the patient's goals are. And you could just be as open as, what are your goals with your oral health? What do you want long term? What do you see as the outcome of these appointments? And really dive in deep to what the patient needs and what the patient wants, and then just be frank with the patient and say, I'm here to support you. How can we work together? So if you have more time to spend with patients, then you can actually apply more of the motivational interviewing, guiding strategies, and principles. If you have that limited time, that 5 to 10 minutes, that's where brief motivational interviewing comes in. It's just that elicit, provide, elicit, little snippets of open questions, asking permission, giving a little bit of information, finding out what that means to the patient, and then hopefully at the next 4-month periodontal maintenance or 6-month prophy, you can build on that conversation again. All right. How would you, am I an elderly person that's self-sufficient and their home care is not where it should be? Well, with motivational interviewing and the elderly community, if their home care is not sufficient, it would be the same as any other adult if they're 20 years old, 30, 60, 80, 90. You follow the same MI principles. Now, if they're up in age and there is Alzheimer's or dementia, then I would recommend not to use motivational interviewing, that you might have to go to the tell, show, do, or a teach back method. But if they are cognitively self-sufficient and their daily activities and home care, their ADLs, are able to complete that, then the same MI principles fall into line. If there's any resistance and they don't want to talk about it, then you just roll with it. And then hopefully next time you come in, you build each time they come in. And it might take 3 years of a 4-month periodontal maintenance to even get into actually them sharing a goal with you. This is not something that happens quickly. This is not something that happens at one visit. You might get a patient that's really open to share with you, and you're just moving along and making goals together and seeing those goals out. And then you might have that patient that you work with for 5 years and they finally opened up about one of their outcomes. But if they are able to do their daily living, brushing, flossing, and they're cognitively there, it's the same MI rules. It's nothing to do with age. All right, next question. Do you think MI skills are easier to practice depending on the personality of the provider? I do think that's true. That's my own opinion. I don't have any evidence to state certain personality types are better at MI than others. I'm a talker, so this MI has actually been a little bit difficult for me in my early training days because I have to stop talking and I actually have to listen. During an MI conversation, the provider should do less talking. The provider should do more listening and allowing the patient to speak. That's been very challenging for me personally. Students, when I'm teaching motivational interviewing, some students really pick it up. Other students end up struggling with it, but I don't have any evidence to state a certain personality is better at it than another. All right. Have you studied or used MI with new patients? New patients to an office, I would say no. In my clinical trial, everyone I enrolled technically is a new patient to me. They are a patient of record at the School of Dentistry, but they are a new patient to me. I've never seen them. I had no history with them whatsoever. So essentially in my clinical trial, they are new patients to me. But MI, it can be used with a new patient appointment, especially if you're going into oral home care. And if you're fine about any habits they may have, you can just pose a simple open-ended question. Let's say the patient is a smoker or vapes. You can just ask questions. How does vaping fit into your life? How does smoking fit into your life? What type of benefits do you have from smoking? They may tell you, well, it's a big stress reliever. I have really long days at work, or I really like smoking in the car going to and from work. So you can find out how smoking fits into their lifestyle, and you could just kind of leave it at that as a new patient and document it in the SOAP note, and then follow up on it the next time they come in. You don't have to come up with a solution at the first appointment. All right. In your opinion, what do you think about giving handouts to the patient with pictures, understanding that there may be different levels of comprehension, vocabulary? Handouts are great. There is another excellent CE coming up with Professor Cindy Stahl on HPV, and I know she's going to have a little bit of MI in her lecture as well. Cindy and I have incorporated motivational interviewing at the University of Minnesota with students having discussions on HPV and HPV vaccine uptake. And part of that training with students is asking permission to provide a brochure of additional information. So brochures are great. You can use that EPE, ask that open question, ask to provide information. You could say, may I provide you with a brochure about periodontal disease, about smoking and diabetes, or whatever the case may be, and leave it at that. I mean, that is aligning with brief motivational interviewing. You're assessing motives, you're raising awareness. So great question. All right, does MI work with the older population? There is evidence, this is similar to a question earlier, there is evidence that motivational interviewing is applicable with many age groups, and also is applicable for caregivers and parents of children. But again, when we get into older populations, when we're getting into geriatrics, we want to make sure that there's not Alzheimer's or dementia or any cognitive problem where MI is not applicable, where it should be tell, show, do, or teach back. We also need to be mindful of dexterity and making sure if we're motivating them to floss, can they do that physical task? So with geriatric populations, we have to think more holistically and making sure that they have the cognitive and the physical ability for whatever you're trying to support them to achieve. But absolutely, it can be used for geriatric populations. But we do need to think on a more holistic level, making sure that we're not supporting them to floss if they can't wrap the floss around their fingers and floss because of arthritis. So we want to keep that in mind. All right, the second part was uncooperative patients like adults. Should they be set limits to? Anytime you have an uncooperative patient that's unwilling to discuss behavior change, you want to roll with resistance. Because if you push that patient to have that conversation and they don't want to have it, then all that's going to do is ruin that patient-provider relationship. It's going to have animosity. That patient may not want to treat with you again at the next appointment. So if there is any resistance, you definitely want to take a step back, thank the patient for whatever information they gave you. You know, oh, thank you for having that conversation with me. May I check back next time? And leave it at that and say, let's get back to your appointment. Let's get down. I'll get the dentist for the exam. Let's finish up with the scaling, whatever you're doing next in the appointment. So if there is an uncooperative adult, you don't want to push them, because if you are pushing them or giving them advice, then you're essentially not utilizing motivational interviewing and you're not aligning with the spirit of MI. All right, next question. Regarding my question about MI models, I was thinking in terms of health behavior change models. Yes, that's what I thought you meant. So earlier in my slide, I mentioned the health belief model and the trans theoretical model, which is the stages of change. Those are the two models that align most with motivational interviewing. So if you are trying to do some MI research or be able to apply MI better during your patient care, refer back to the health belief model and the trans theoretical model, which is the stages of change. knowing those two models and knowing where your patient is on that model, that will help you decide what MI guiding strategy, what rule, what process you should follow that would be the best to evoke the patient's internal motivation or the best way you can support them. So yes, those two models. All right, can you please say the website again? Yes, it is MINT, M-I-N-T, just like a mint you put in your mouth, M-I-N-T. That is the Motivational Interviewing Training website. All right, do you have a way of connecting you for future questions? Yeah, absolutely. Please, Lance, who wants to connect for future questions, please get with Dr. Peterson. She would be able to share my email with you. So I'm more than happy to answer questions down the road. All right. What about cognitively insignificant? How do you care about providers on board and their providers' patients? Is there a way? So yes, if there is anyone that is cognitively impaired, motivational interviewing is not really the way to go. You want to more focus with tell, show, do, very simple directions, very lay terms, making it very easy for them. Motivational interviewing is more applied to individuals that can make their own decisions and can make their own choices on whether or not to change a behavior. So you do want to be careful with that. And then how do you get, oh, that went so fast. It was another question about how do you get providers on board? Any other resources such as books? Yeah, actually, let me pull out a book I have right here. This one is one of my favorites. It is The Rams Are Its Health, Behavior Change in the Dental Practice. Let me get it close. As you see my sticky notes, this is one of my favorite MI books. It is, hopefully you guys can see it, maybe take some screenshots of it. It's a really thin book. It's a great read. There are a lot of different ways to implement MI. It's one of my favorites. It's a great read. To my knowledge, this is the newest edition. There is not, and I think it's 2010. I think it's a little bit dated, to be honest. But yeah, this is one of my favorite, but there's a couple of different MI books. This one you can probably get on Amazon, pretty inexpensive. All right. So that's the question about the book. Let's see. Could you give more yes. So the next question is, could you give more examples of reflective listening during your dental exam and when discussing treatment plans? Yes, so I do want to share my screen. This is something, I had a feeling this question would come up. This is something I share with students. So this is a box. It's qualities of successful changers, reflective listening, and affirmations. So if a patient says something and I give this to my students, so if they're at a loss for words, and if the patient says, oh, I am willing to incorporate flossing in my daily routine. So you could say, oh, you're really flexible to incorporate flossing maybe at night. So that's a reflective statement. If someone says that, I'm really trying to brush more and I've been doing a better job at it, you could say, wow, it really shows you're being very diligent with your home care and your plaque removal. So these are just some words that I give to students of how they can use these words in a sentence. So you can reflect what the patient said to you, how you can reflect it back, and make sure you put some high quality word affirmation to let them know you're listening. So this is an example of what I give to students. Let me get back to the question page. All right. Okay, do you suggest MI at every 6-month visit if the patient comes in regularly, especially if they continue to have bleeding, plaque, and buildup? Yes, I suggest, and the way I teach motivational interviewing to students is we don't just put our MI hat on and say, okay, we're going to MI the patient. Motivational interviewing starts when you greet the patient from the lobby and you get the patient back. And you greet them with a smile and you're happy to see them and you thank them for coming in and you thank them that they made their oral health a priority and they came into that dental appointment. So that rapport building that way to support our patient in a non-judgmental manner starts at the beginning of the appointment and it goes throughout the whole end of the appointment. So if a patient is still struggling with bleeding or plaque buildup, anytime that you can have those conversations to help support them, to help motivate them, that is best. If we go back to the stages of change, that relapse is very common. You can have a patient that is going to do excellent with brushing and flossing after the hygiene visit, and then they relapse and they go back to old behaviors. So then when they come in for their next periodontal maintenance or their prophy, it's atrocious again. There's plaque and calculus everywhere. So yes, I do encourage that the motivational interviewing is continuous and you're always working with that patient because change doesn't happen overnight. Behavior change takes time and work. So for you to really be that support system for that patient and have that patient-provider relationship, you do have to build on it at each appointment. Great question. How would you use MI to start a conversation with parents who put their children to bed with bottles and are resistant to change? Great question. There's a lot of MI evidence on how you encourage parents or caregivers of children. So you could just start the conversation with the parent. What is the nightly routine with your child before bed? And then the parent should say A, B, C, or D. I put the child to sleep with a bottle. You could ask the question, what's in the bottle? Because if it's water, it's okay. If it's juice or milk or something else, that's totally different. So then you can ask that question, well, what do you know about tooth decay and baby bottles at night? Find out what they know about it. They may not know any connection. So using that EPE, that allows you to find out where the patient's level of knowledge is and their health literacy. They may not know the consequences of it. And then you can ask permission to share advice, share evidence on baby bottle tooth decay, and see where that patient's at. And I will tell you, a lot of the MI research with parents or caregivers of children, especially with high ECC areas, they find that motivational interviewing does increase parents' knowledge and health literacy, but it doesn't necessarily change their behaviors. And this is also true in low social economic areas with early childhood caries. They find that the implementation of MI improves knowledge and health literacy, but it doesn't always change behaviors because there's so many upstream variables in these given communities to actually change their behavior habits. So that is another area of emerging motivational interviewing, and my best advice is the EPE, and try to be as supportive as possible and non-judgmental, yet provide information with permission. All right, can we email if you have questions or want to follow up? Yes, Kay, please contact Dr. Jo Peterson, who is organizing the CEs. She can pass on my email if you have any questions. All right, I work in pedo, parents are in the room. How do you handle, oh, that's a good one. How do you handle when you can't read the parent? Yes, oh, we love those helicopter parents, don't we? The best way I can say is trying to go back to the basic MI principles and try to build rapport with the patient, with the parent. But again, even in a pedo setting, the way I teach students is we always address a child and we ask the child questions, and then the parent should be there to fill in the gaps. So whatever the child tells you about their home care or what they're doing or what they're eating, whatever gaps of information, then we use the parent as that person to fill in those gaps. The best advice I can give you is just try to follow the MI principles and chisel away at that parent until you break through and build that relationship. Some patients, it's really easy with the parent and you can easily talk to them. There's other parents you don't know as a hygienist if they like you or don't like you treating their child because you can't read them. The best advice is don't give up and keep trying to work at it. And hopefully the parent does come around so you can better support the parent and the child's oral health. How do you keep a patient motivated who says they have been working hard with their teeth, but it doesn't show? Yes. So this is developing discrepancy. I brought this up in my lecture. When the patient says that they're doing something, but their behavior doesn't align with it, or the patient says, oh, I don't like that my gums bleed, but then they won't floss. The best thing that you can do with that is, again, trying to go back to your OARS, asking the open-ended questions such as, you know, you've been working really hard at taking care of your teeth. You're telling me that you're doing A, B, C, and D. We still see plaque and bleeding. What do you think could be causing it? Because maybe the patient's not working as hard. Maybe they're not being forthcoming about their home care, or the patient might give you some additional information about their health or their home care or their habits that you had no clue about. They might be brushing and flossing before bed, but then they're munching on chips before they go to sleep. So then it kind of defeats the purpose that you brushed your teeth, but then you ate before you went to bed. So again, just telling the patient, affirming that you've been working really hard, and you tell me that you're doing all these great things to keep your mouth healthy, but we're still seeing the bleeding, or we're still seeing plaque. What do you think could be the cause? 9 out of 10 times, the patient knows what they're doing, or the patient knows what is causing the issue. So just trying to dig a little bit deeper, and then hopefully that patient provides a little bit more information to help you get to the bottom of it. All right, using the same reflective statements when you see positive change, and ask if you could share with us what they are doing, keeping the support going too. Yes, that's exactly it. Using those reflective statements, being positive, that's exactly one of the keys to motivational interviewing. All right, can you repost your last information chart? Yes, let me reshare it. Bear with me. So this is just, I'll scroll to the top. These, since again, I have novice students, so I provide open-ended questions because many of them end up putting, can you tell me how you take care of your teeth? Well, technically, that's a yes or no question, because no, maybe I can't tell you how I take care of my teeth. So I always tell students to take can away from it and use, how do you take care of your teeth? How do you take care of your gums? What is your home care routine? So again, I feed these questions to students, and MI is not a script. By all means, you can't follow a script, but you need some certain tools in your toolbox to get through these patient conversations. So again, I give these open questions, but then when we get to the reflective statements, again, you don't want to start with I. You want to be careful that you don't say I or you. So you do want to be careful there. But here are the successful changers. So if you want to take a screenshot, and again, these should be used in a sentence format, but sometimes when a patient is just open and talking, you could just throw out a one word. If they're talking about a challenge, you could say it's tough and just nod. If someone talks about that they just found a new article and they're trying something new, and say, wow, you're resourceful. So sometimes you can use these as just one phrase statements to let the patient know that you're listening, and using these to help build their confidence. Usually I recommend that you reflect what the patient said to you in your own words and try to throw one of these words into it, because then the patient's hearing what they said in a different format that you're delivering to them, and then you threw a positive affirmation into it as well. And then it helps keep the conversation going. So hopefully that helps. All right, so it looks like the Q&A session is done. That was fun. I hope you enjoyed the nail in the forehead video as much as I did. All right. So thank you again for joining. And if you have any questions, you could contact Dr. Jo Peterson, and she can share my email. Thank you again. I hope everyone has a good night. Stay safe and take care.